All right, why don't we go ahead and get started? First of all, good morning, everyone, and I hope everyone is weathering this winter storm. It's great actually to have all the snow. We need the water. It looks like things have cleared up and we're headed for a good week. And we're all gathered on Zoom this morning to celebrate a great resident from the University of Colorado. And we have a very distinguished visiting professor with us, Dr. Julianne Sosa, who I have known for many, many, many years. And I have worked together and we've done a lot of things together. Let me first introduce Dr. Fox. This lectureship was established by his friends and colleagues. And Dr. Fox fell victim to cancer at the age of 28 during surgical residency, basically. He's a native of Dallas, Texas, attended Dartmouth for undergrad and then Harvard for medical school, and then came to the University of Colorado to start his residency. And this was during the time of the Vietnam War. And after 3 years of residency, he was drafted and was stationed first in Massachusetts and then in northern Thailand. And I think he and I could have been living on the same Air Force base for a period of time. While at Colorado, he met his wife, Jane Crozier, who I've had the pleasure of meeting several times also. In northern Thailand, he fell very ill and was evacuated back to the United States and was diagnosed with a blood cancer and quickly progressed, unfortunately. He was really beloved by his fellow residents and the faculty, and because of his contributions and personality and his teaching abilities, this lectureship was established. And I can't think of any better person to be a visiting professor with this lectureship than Dr. Julianne Sosa. She's professor and chair at the Department of Surgery at UCSF and holds the Leon Goldman Chair. She's a native of Montreal, Quebec, and then went to Princeton as an undergrad, did a master's at Oxford in England, came to Johns Hopkins for her medical degree, which is where I first met her. She graduated from Johns Hopkins AOA and then entered the general surgery program. Even though I am much older than Dr. Sosa, we did overlap for multiple years. And then she then went on to faculty positions at Yale and then led the endocrine team at Duke before she was recruited to UCSF in 2018 as professor and chair. She is extremely well published with 330 peer-reviewed publications. She's NIH funded. She's invited all over the world to give lectures. She's a leader in multiple national and international organizations. She's an excellent technical surgeon, and I know that because I've operated with her many, many times, both as co-residents and also as a junior faculty member. She's a true disciple of Halsted, and she follows a lot of the Halstedian principles. On top of everything else, she's a trailblazer. She's a wonderful person, and my wife, Christine, and I really enjoy spending time with her and Satsiana, who's also a distinguished surgeon, by the way. So, Dr. Sosa, thank you so much for joining us this morning and delivering this lecture on thyroidology. We really look forward to this talk.
Thank you so much, Dr. Schulich. And let me go ahead and share slides. Is everyone able to see that? All right. So good morning, and thank you so much for that warm and kind introduction. It is an absolute privilege to be able to visit with you in the snow from sunny Northern California and to be able to present the F.A.C.S lectureship. I'm going to be a little controversial today, a little edgy today. I'm hoping some of my endocrine surgeon and thyroidology colleagues from the University of Colorado are joining us so that they can respond to the provocative comments that I make. These are my disclosures. They do not pertain to the content of this discussion, which will be restricted to differentiated thyroid cancer. My disclosures relate to medullary thyroid cancer. So Dr. Schulich said we've known each other a long time. Indeed, it is a long-term friendship that we've had. And while Dr. Schulich is a friend and colleague, he is also a mentor and sponsor. And those are two very unique attributes that I value very, very much in academic surgery. I know I must be as old as dirt when I show you these photos, but on the left, you'll see a picture of me in the graduating class of 1994 at Johns Hopkins. The arrow points me out, otherwise you wouldn't see me behind somebody's hat. And there I am on the right, on the halls of Halstead, smiling. And I am eternally optimistic. And I once said, I think I may die of optimism. But it was a wonderful time. Dr. Schulich was a wonderful senior resident and assistant chief of service. And thank you, Dr. Schulich, for bringing me to Colorado today. So I'm going to start with this. In the old days, we used to travel. We used to go places on planes, and I would read airplane magazines. And I actually took this photograph from an airplane magazine. It's a picture of Brooke Shields. To the best of my knowledge, Brooke Shields does not have thyroid cancer, but it's a very interesting epidemiologic comment. And we're going to start with epidemiology. It says it's not just looks that can kill. Have your neck checked for thyroid cancer. So two controversial things said in this advertisement, and I would argue they're both untrue from a public health perspective. The first assertion is that thyroid cancer kills. And of course, fortunately, thyroid cancer rarely kills. Survival from differentiated thyroid cancer is in excess of 95 to 98% at a decade. Secondly, it suggests that we should screen patients for thyroid cancer, either with radiographic studies or physical examinations. But of course, the US Preventative Services Task Force a couple of years ago recommended against screening asymptomatic adults. So beware what you read in airplane magazines. But I think it is important to start with facts, epidemiologic facts. And a fact is that, and I used to say there's been a pandemic. I've changed that. I now say there is an epidemic of thyroid cancer in the United States, with an incidence that has risen by more than 30% over the last 3 decades. And this explosion in thyroid cancer was seen in every demographic subgroup: women, men, young, old, and in all racial and ethnic groups. Well, what is going on? What is the explanation? So a pivotal paper was published by Welch and Davies in JAMA in 2006. Let me walk you through the pivotal images from that study. Starting in the left upper hand corner, you see the rapid rise in the incidence of thyroid cancer, and you see the genesis of this appears to be a single histologic subtype, papillary thyroid cancer. And to the right, we see incidence broken down by tumors of different sizes. And you see it is the smallest tumors, those 0 to 1 centimeter, which we conventionally call papillary thyroid microcarcinomas, appear to be largely the engine. And then finally, the most controversial figure in the center, you see incidence rising and you see mortality flat, leading the authors to conclude, not surprisingly, we believe increased diagnostic scrutiny is the most likely explanation for the apparent increase in incidence. That is, it is all overdiagnosis. So do we have truth? Is that truth? Well, just like we used to say, the icebergs, the whole truth is often hidden from view underneath the surface of the waters. I say, and I don't want to get political in this talk, I think we've all had enough politics to last a lifetime, but just as the icebergs are melting, so too might be truth. Well, that last figure, shown again on the left from Welch and Davies, really bothered me. And I must have looked at it and read that paper 20 or 30 times. What bothered me? So what we know is that the incidence of thyroid cancer is on the order of 45 to 50,000 new cases per year. So it's a very large number. But mortality, fortunately, is a scarce event. It's very rare. And yet both numbers, a large number and a small number, were put on the same arithmetic scale by Welch and Davies. So I wondered, is it possible that that arithmetic scale is muting changes in mortality? Well, I'm not an epidemiologist, but I have friends who are epidemiologists, and I recommend you all have a friend who's an epidemiologist. So I called up Carrie Kitahara, an epidemiologist at the National Cancer Institute, and I said, Carrie, can you take these two numbers and plot them on a logarithmic scale for me? Well, it took her 30 minutes, and she sent me back the figure on the right. And again, you see incidence rising with an annual percentage change in excess of 5% per year. No surprise there. But then look at mortality. Mortality is actually not flat, and mortality actually is appearing to rise. And with that simple intervention, we published this figure and an associated analysis in Nature Reviews. But more importantly, we went back to that Welch and Davies study, and we redid that study with two important and only two important changes. And our findings then were published in JAMA in 2017. Quite controversial. Let me walk you through the paper. So we used, same as Welch and Davies, SEER9 for our incidence data, nearly 78,000 patients, representing about 10% of the US population with thyroid cancer. Important demographic, clinical, and pathologic information. Our mortality data came from death certificate information from the National Center for Health Statistics. And then we changed the first thing from Welch and Davies. Instead of using mortality, we used incidence-based mortality. And incidence-based mortality is probably a better outcome when you're looking at an event that is relatively rare, which mortality from thyroid cancer is. Like Welch and Davies, we calculated age-adjusted rates, annual percentage changes with join point regression analysis, and then we changed the second thing from Welch and Davies, and that is instead of using that arithmetic scale, we moved to a semi-log scale on our y-axis. And let's see what differences those two changes made. So starting with incidence of papillary thyroid carcinoma over 30 years. And what we see is, yes, the incidence of localized disease rose, but so too did the incidence of regional and distant metastatic disease, which really doesn't fit the story or narrative of overdiagnosis. Then incidence by size of the tumor. Yes, these papillary thyroid microcarcinomas exploding in incidence, but so too are tumors over 4 centimeters in size, nearly the size of a golf ball. No one would argue that this represents overdiagnosis. And then switching gears and looking at incidence-based mortality, the incidence-based mortality for thyroid cancer rose at a rate of 1.1% per year. The good news is in the United States, we are winning the war on cancer with improving survival for all but 4 or 5 cancer diagnoses. Number 1, hepatocellular carcinoma. Number 2, thyroid cancer, we now know. And then when we look at incidence-based mortality, based on the stage of the disease, it is increasing for tumors of all stages, including the smallest tumors, those tumors less than 2 centimeters in size, at an annual percentage change of 6.8% per year, suggesting that the underlying biologic profile of differentiated thyroid cancer may in fact be shifting. So yes, we agree with Welch and Davies that incidence rose at greater than 3-fold over 30 years. It impacts all subgroups and especially papillary thyroid carcinoma. But in contrast to Welch and Davies, we concluded that incidence-based mortality rose by 15% over the same time period. This impacted, again, virtually every clinical and demographic subgroup, and again, especially papillary thyroid carcinoma. So we agree with Welch and Davies. Yes, overdiagnosis represents a majority of the explanation for the epidemic of thyroid cancer, but it is not the only explanation. And we are doing ourselves a disservice if we pivot and look away from looking for cures for patients with advanced stage disease. So what is going on? If we argue that yes, overdiagnosis is a portion of the story, what is the rest of the story? So as many of you who follow cancer know, overweight and obesity are associated with many cancer diagnoses, and I would argue the same is true for thyroid cancer. The incidence of obesity is rising in the United States. Over this 25-year time period, it went from 11% to 24%, and the prevalence of overweight went from 30% to 37%. And what is very interesting is that if you track the increase in incidence of overweight and obesity, you will see that the proportion of incident papillary thyroid cancers that are attributable to overweight and obesity increased over this time period from 11.4 to 16.2%. But this is exquisitely true for those tumors over 4 centimeters in size, where it went from 51.4% to 63.2%. So that is attributable risk for papillary thyroid cancer to overweight and obesity. And I would argue some of what we are observing is artifactual and related to the lexicon of thyroid cancer that we use. So the reasons I think underlying papillary thyroid cancer incidence are multifactorial. And what we know is that incidence is rising, except for that of follicular variant of papillary thyroid carcinoma. And almost certainly this is because of a change in nomenclature. When we went from calling non-invasive encapsulated follicular variant of papillary thyroid carcinoma to an in situ neoplasm called the NIFT-P. And when this happened, which was in this time period, you see that the follicular variant of papillary thyroid carcinoma declines as the incidence of this new clinical entity, the NIFT-P, rises. At the same time, the incidence of papillary thyroid carcinoma, the classical variant, and other histologies all continued to rise. What happened as a result of this, the change in nomenclature, more aggressive guidelines to avoid the overdiagnosis of thyroid cancer? Well, we've been able, fortunately, to mute this epidemic of thyroid cancer, and we are now seeing a plateau in incidence, which we believe is important and a good thing. Well, does epidemiology carry weight in Washington, D.C.? I don't know. I doubt it. But what definitely carries weight is cost. So this is very interesting. These are data for the cost of thyroid cancer care. And you see as incidence rises, so does the cost of care. But thyroid cancer is quite unique among cancer diagnoses. For most patients with cancer, costs are assembled over the last months, weeks, days, maybe even hours of life. So disease, deaths shown in blue. But that's not true for thyroid cancer, where many of the costs are assembled in the surveillance phase. Why? Because most patients diagnosed with thyroid cancer are diagnosed in youth. They do not succumb to their disease, and they live with their disease, accumulating the costs of surveillance and remedial treatment. And what are the sequelae of such? It is bankruptcy. So as many of you know, we now talk about this concept called financial toxicity of cancer. Any cancer diagnosis will increase a patient's risk of bankruptcy by twofold. But thyroid cancer really stands out in that it increases a patient's risk of bankruptcy by 3.5 times, much more than more mortal cancer diagnoses like lung cancer, uterine cancer, melanoma, or breast. Well, many people say that's counterintuitive. How can that be? It's because young patients do not succumb to their disease. Rather, they assemble cost after cost from surveillance and remedial therapy. And sadly, today in the United States, it is the youngest Americans who are the least well insured, or frankly, uninsured. So what can we do about this? Well, I think what we should do about it is to standardize practice. If we can standardize practice, we can standardize the quality of the care that we provide. And as you know, there's been an explosion in the number of practice guidelines that have been issued by virtually every professional society and association for the management of benign and malignant diseases. And if I were going to summarize the status of thyroid cancer practice in the United States today, what we're doing in many ways resembles what we were doing 20 or 30 years ago. These are the current American Thyroid Association guidelines for the management of differentiated thyroid cancer. I do want to highlight Dr. Brian Haugen, who leads endocrinology for the University of Colorado, a great friend and colleague and a thought leader in the arena of thyroidology. Whenever you read guidelines, before you delve in, roll up your sleeves and evaluate the quality of evidence, I always say, look at who wrote the guidelines, because all of us, for better or worse, carry with us unconscious and implicit bias. It impacts so much of what we do. So who wrote these guidelines? So it was 4 surgeons, 2 otolaryngologists on the left, 2 endocrine surgeons on the right. 2 were veterans of the 2009 guidelines. 2 of us were newbies. In many ways, the American Thyroid Association is equitable and fair. They're still working on gender equity, it appears. So what do the guidelines say? Well, in many ways, current guidelines for the management of thyroid cancer share a lot of tenets with other cancer guidelines. You want to improve survival. You want to reduce the risk of recurrence. You want to facilitate long-term surveillance. You want to permit accurate staging of disease. But what is increasingly true in thyroid cancer and in many cancers is we acknowledge that we must minimize treatment-related morbidity. Well, is that such a novel principle? Probably not. It's something each and every one of us do in our clinics every day. On the one hand, we want to avoid the overtreatment of indolent lesions, but at the same time, we want to avoid the undertreatment of clinically significant cancers. And how do we do that? We weigh many things: the risks of misdiagnosis. We weigh patient preferences, increasingly at the epicenter of decision-making. We wonder about medical legal considerations and potentially fear them. And ultimately, we want to reduce the costs to patients and payers. So let's walk through these guidelines and talk about the controversies that currently exist, starting with those tiny tumors less than 1 centimeter in size, which we call papillary thyroid microcarcinomas. So this is a paper, a thought paper from 2014, but it really shifted our thinking about these tiny tumors, raising for the first time whether their identification and surgical eradication was a worthwhile goal, or whether, in fact, we could actively surveil tiny tumors, leaving them in patients' necks. I always say to Doctors Ross and Tuttle, if we're going to actively surveil these tumors, we better do that more fastidiously than the editors of the journal Thyroid, who could not spell micropapillary correctly. Well, where do the data come from to support active surveillance? They come largely to date from Japan. Many studies published about a single cohort followed over many decades. This is one of my favorite papers from that series, back 2014, looking at more than 1,200 patients followed for 75 months, divided into 3 age groups. All of these patients had papillary thyroid microcarcinomas, and these cancers were left in the neck unless they enlarged, developed new lateral compartment lymph node metastases or developed tumors in excess of 1.2 centimeters in size. And what Dr. Ito and colleagues found is something truly extraordinary. And that is, at a decade, just 8% of patients experienced any enlargement of their tumors, and 3.8% only developed nodal metastasis at 10 years. When they then divided the cohorts into 3 separate age groups, they determined that the proportion of patients was lowest in the old patient, shown in a solid line, and it was highest in the youngest patient, showed in a dotted line, with regard to progression of disease. And our multivariate analysis, young age indeed was an independent predictor of progression. So what did the authors conclude? If you're going to actively surveil a patient, that is better done in an older patient. But even if you surveil young patients who have more progressive disease, there is adequate time to delay surgery and rescue the patient without survival compromise. So should we embrace active surveillance in the United States? Well, I always say, before you go running and doing something brand new, figure out what you're doing currently to understand whether that would be a small change, an incremental change, or a sea change. So here are survival data in the United States at a population level for patients with papillary thyroid microcarcinomas compared to the general US population. Let me caution and say that these are not statistically significantly different, but if anything, papillary thyroid microcarcinoma patients survive a little longer than the general population. Well, a lot of people say, Julianne, how is that true? But of course, if you have a 2 or 3 millimeter cancer found in your thyroid, you almost certainly have more fastidious and superior access to healthcare than the average American. So what are we doing for these patients? Sadly, what we're doing is total thyroidectomy. Nearly 3/4 of these patients, 73% of patients, are having their whole thyroids removed for these tiny tumors. Now, a lot of people say that misrepresents the data, Julianne, because most of those patients have incidental papillary thyroid microcarcinomas discovered on surgical histopathology, but they actually underwent surgery for something like a multinodular goiter, Graves' disease, symptoms of compression. But I don't think that's true. Why? Because not only did they have total thyroidectomy, but they actually underwent adjuvant radioactive iodine treatment in nearly 1/3 of cases. So my point is that we are not only overdiagnosing these tiny tumors, but we are also over-treating the patients with them. So what do the recommendations actually say if you're taking your board exams? The recommendations are do a thyroid lobectomy for a papillary thyroid microcarcinoma. But what a lot of people overlook in the recommendation is this word, where we introduced for the first time the word if surgery is chosen, which was intended for the first time to open the door a crack to permit active surveillance as an appropriate treatment option. Proceed cautiously, however. Let's shift gears and go one size bigger to the low-risk differentiated thyroid cancer. That is a tumor 1 to 4 centimeters in size confined to the thyroid without evidence of metastatic disease. This is the age-old controversy, lobe versus total. On the one hand, people who say take the whole thyroid out, they want to eradicate what is often multifocal and bilateral disease. They want to facilitate radioactive iodine and facilitate easier recurrence detection with thyroglobulin levels. Well, those who advocate for lobectomy say, who wants replacement, let alone supplementation? It's an indolent disease. Nobody succumbs, and there are more complications with bigger surgery. So this is a figure frequently shown to make the point that the more you do, the better you are. If you go from left, Duke blue, to right, UNC blue, you'll see that with increasing volume, the complication rate declines for both lobectomy and total thyroidectomy. But that's not why I show this figure. I show this figure because even in the hands of the high volume surgeon shown in UNC blue, you see that the rate of complications following total thyroidectomy is nearly twice that as for thyroid lobectomy. So even in the hands of experienced surgeons, bottom line, total thyroidectomy is a more dangerous operation. So why for so many years did we do total thyroidectomy exclusively? In fact, that's all I knew until about 5 to 6 years ago. Well, it's interesting how threadbare data are when you actually look for the evidence supporting some of our practices. And it was basically one, sounds familiar, one pivotal study published by an excellent scientist, Dr. Villamoria, in 2007, looking at 52,000 patients with papillary thyroid carcinoma. And largely based on this population level study, the ATA in 2009 recommended total thyroidectomy for tumors over 1 centimeter in size. So why did they do that? Here are the data from Villamoria et al. And eyebrows were raised when these data were presented. And what you see is that thyroid lobectomy compared to total thyroidectomy was associated with a 31% increase in the risk of death. Really surprising. Well, after that paper was published, a lot of people did scratch their heads a little, not about Dr. Villamoria and not about the quality of the analysis, but rather, as is often the case, the quality of the data and the fact that many important independent variables were not contained in the data set that the scientists deployed. And then Mendelsohn in 2010 performed a similar study in a different database and was unable to replicate the findings. So you'll learn a pattern of behavior of mine, which is sometimes you don't have to ask a new question to have impact. You can ask an old question in a new way. And what we did was we took the Villamoria study and redid it with an enriched data set. And I show you the picture of Dr. Adam, who led this study as a third-year categorical general surgery resident at Duke University. You can change practice as a learner. Extraordinary. So he used the National Cancer Database, looking at a number of demographic, clinical, and pathologic variables, again, predicting survival and comparing lobe versus total. Here are the data, a bunch of demographic characteristics. You'll see statistically significant p-value. I would argue these are not clinically significant differences, but these were the variables not contained in Dr. Villamoria's data set, and you see that they are clinically and statistically different between total and lobe, and not surprising. Among totals, more multifocal disease, more extrathyroidal extension, more metastatic disease, and more adjuvant radioactive iodine deployed. But when you take this enriched data set and repeat the multivariate regression analysis, we came to a completely different conclusion, and that is survival is equivalent between total thyroidectomy and thyroid lobectomy. So here are the 2009 guidelines. Total thyroidectomy is recommended, and here are the current guidelines, often misread to read lobe, not total. Rather, what the guidelines say is lobe or total are both appropriate. They just have different risk-benefit ratios. In the end, who should make the decision? Patients, as they should sit at the epicenter of decision-making. So let's switch gears again, say something and do something controversial. We're now going to hop outside the thyroid gland and talk about the lymph nodes in the neck. So everybody knows the ABSITE and the board exams love to ask staging questions. And thyroid cancer, differentiated thyroid cancer staging is a frequent target of questioning. Why? Because it doesn't make a ton of sense. It's super quirky. And what's quirky about it is that it is divided into two staging systems, one for young patients and one for older patients. Now, this is the 7th edition. We're now on the 8th edition. I'm showing you the 7th edition because these are the data that I have the analysis for. Currently, the 8th edition cuts at 55 years, not 45 years, but there's still this age threshold. When you're younger, we forgive a lot. And you can only be stage 1 or 2. You cannot be stage 3 or 4. You either have disease confined to the neck or extracervical disease. What's the real point? Lymph nodes that are metastatic in the neck don't count. In older patients, however, over 45, now 55, you can be stage 1, 2, 3, or 4, and metastatic lymph nodes in the neck significantly upstage you, in fact, to stage 4A disease. Well, that's kind of crazy. There is no other cancer diagnosis staging system that is similar to this. So does it make sense? So these are data from Zaid Fudum back in 2008. He was able to confirm this quirky staging system. But then Tran Cao in 2012 could not find data to support the AJCC UICC staging system. So you probably know where I'm going with this. Ask an old question in a new way. This is a study from JCO Impact Factor 26, led again by a third-year categorical general surgery resident at Duke. And we asked 2 simple questions. Does the presence of lymph node metastasis and the volume burden of disease you have impact survival if you're young? And if so, is it possible to stratify risk of death based on the number of metastatic lymph nodes you have? So we used 2 large databases, NCDB and SEER. Many of you, I'm sure, in the audience are familiar with them. We did a lot of conventional multivariate regression analysis using important independent variables, again, to predict survival, which is what staging does. It predicts survival, not recurrence, although subsequently we have shown that these are also true for recurrence. And we took young patients, less than 45 years of age, and we divided stage 1 patients, so disease confined to the neck, into 2 groups, those with and without metastatic lymph nodes. So we did conventional regression analysis, and then we did something kind of cool. And that is we used something called restrictive cubic splines. Now, if you're not asleep already, hopefully you're not, please stay awake for this. It's not hard to understand, and it is super powerful tool to have in your toolkit if you are an academic surgeon. So linear association is a presumption of multivariate regression analysis. So what is a linear association? You're driving super fast, too fast, you hear a police siren, and you slam on the brakes. The faster you were going on the x-axis, of course, the longer it takes for you to stop, shown on the y-axis. That's a linear association. We heard, I'm from Canada. In Canada, we talk about 2 things, cold and colder. Maybe the same is true in Colorado, not sure. So here are seasonal temperatures in Montreal by month of the year and season. And of course, there is no linear association between temperature and month. So what do restrictive cubic splines do? Something very simple. They relax the linearity assumption that is otherwise made in multivariate regression analysis. So let me show you how to use it. So here's our adjusted survival analysis. We are predicting death, not survival. This is from NCDB. And what you see, if you are a young patient with metastatic lymph nodes, you are more likely to die with a p-value of less than 0.05 than a similar young patient without metastatic disease. That is not what the AJCC UICC staging system says should happen. And what is true in SEER, the same as was true in NCDB, metastatic lymph nodes in young patients appear to compromise survival. And does the burden of disease in the neck impact survival? It sure does, up to the number 6. Every metastatic lymph node up to 6 lymph nodes confers an increased risk of death. And then after 6 lymph nodes, there is a muted association. So what do we conclude? Lymph node metastases indeed are associated with compromised survival in young patients. Unfortunately, in young patients, we likely are understaging them and potentially, therefore, under-treating them. Well, I'm not super powerful like the AJCC, UICC organizations. But what I can do is I can change what I do each and every day in my clinic. And what do? I aggressively screen young patients for metastatic lymph nodes. A lot of people have misinterpreted that as to say that we are coming for the AJCC. So finally, one last controversy where maybe less is not more, where more in fact is more. And I'm going to show you a controversial but different spin on the practice makes perfect theme. Now, this is an old theme. Many have shown an association between more surgeries done by a surgeon and the likelihood of a superior outcome for their patient. And in fact, many authors in the arena of thyroid surgery have shown this. But the really strange thing from the literature, if you actually review that literature, is never is surgeon volume treated as a continuous variable, which of course it is. Rather, it is relentlessly treated as a categorical variable. And the problem is everyone uses different cut points. Well, who cares about that? A lot of people increasingly care. And the caring really started in 2015, where the Take the Volume Pledge campaign was introduced at 3 academic medical centers, Dartmouth, Michigan, and Johns Hopkins. And what this Take the Volume campaign said is that for those procedures for which there is evidence for a volume threshold in the literature, if surgeons do not meet that volume threshold, they need to stop doing those operations, which you can only imagine was extremely controversial ask at those institutions, because many surgeons had trained all of their lives to do these operations. So what is going on in America around surgeon volume and total thyroidectomy, and is there a volume threshold? So these are national data looking at the volume of total thyroidectomies by individual surgeons. And you can see they extend from a minimum of 1 to a maximum of 157 per year. Well, we took those restrictive cubic splines and applied them to these data to determine, is there in fact a surgeon volume threshold to define what a high volume surgeon is? Not in a random cut point way based on the unique characteristics of individual data sets, but rather based on population level data. And what we found is that in fact, such a number does exist at 25. So each incremental total thyroidectomy performed by a surgeon on average appears to confer on average an improved likelihood for their patient avoiding a complication up to 25, after which this association appears to weaken or even disappear. So for the first time, we actually have an evidence-based definition of low and high volume surgeons. And when you apply this, what you find is distressing. And that is that low volume surgeons are associated with a 55% increase in the risk of complications of their patient on average, along with increased cost and increased length of stay. Perhaps the most disturbing data for the United States, not an institution, not a state, but for the US, is that more than half of surgeons performing total thyroidectomies do so on just 1 occasion per year. And what you see as you go from 1 to 25 total thyroidectomies a year is a dose response effect. This is an association. I cannot prove causation, but it is certainly compelling. So yes, surgeon volume is associated with outcome, but what we're starting to think about is that next level of thinking, and that is there a volume threshold? And for total thyroidectomy, one of the 10 most commonly performed operations in America, last I saw, it's number 6. It is, and sadly in the US, the majority of Americans are undergoing surgery by low volume surgeons. So who cares about surgeon volume thresholds for thyroid surgery? A ton of people care. These are articles that were published in the Washington Post, and the New York Times after that paper was published. More importantly, about a week after the paper was published, I started receiving phone calls from insurers and payers asking about reimbursement and referral patterns and whether they should change how surgery is reimbursed. Certainly, what I said to them is, yes, we live in an era of value-based care, and yes, we are doing better identifying thresholds, but we do not have an adequate supply and an appropriate geographic distribution of high-volume surgeons to accommodate all of the patients that need surgery. And where is the last frontier in 2021 in American surgical thyroidology? I don't know. It actually may be in the arena of nuclear medicine. And what I'm now busying myself doing is unfortunately not studying epidemiology and not studying surgery, but I'm studying radioactive iodine together with my friend Carrie Kitahara in cancer epidemiology. And we are looking at patients who undergo radioactive iodine treatment for Graves' disease. And what I'm afraid to say we are finding is that potentially the exposure to radioactive iodine is associated later in life with secondary solid cancer mortality, raising, I think, an interesting question of whether radioactive iodine will continue to be the prevailing preferred treatment for Graves' disease in the US, or whether thyroidectomy will come to become a more popular option. What do I want to finish with? It's a plea that all of us remain open-minded, open to evidence that will inform change to improve practice and, most importantly, improve the outcomes of our patients. And right now, the American Thyroid Association is in the midst of writing the next iteration of differentiated thyroid cancer guidelines. I have the great privilege of co-chairing that committee with Dr. Ringel, an endocrinologist at Ohio State University, The Ohio State University. These are the 4 surgeons helping us to write these guidelines. And I wanted to finish with a pivot and look forward. So where did Mohammed Adam go, that third-year categorical general surgery resident from Duke? I am thrilled to say that he is now an assistant professor in the Division of Surgical Oncology at UCSF. And I am also incredibly excited to welcome Stephanie Davis from the University of Colorado to San Francisco in the fall. She will be one of our 2 entering endocrine surgery fellows. So Dr. Davis, an early welcome to San Francisco. We can't wait for you to join our Department of Surgery. So with that, I'd like to thank Dr. Schulich and the department for the privilege of presenting today. Thanks so much.
Dr. Sosa, thank you so much for that wonderful talk. And it's great to see that nothing has changed. You're still trailblazing, leading change, and stirring up controversy. So, and that's exactly how I remember you. So I actually have a couple of questions, and you hinted at this, and I'm sure you've studied it. But if you decide to follow somebody with a known small cancer, what's the average number of years you have to follow that patient, number one? And number two is, what's the cost of following that patient? And then there's another cost that maybe we can't measure very well, which is the anxiety of following a cancer in a patient. And how do you bring those variables into play? And should that affect decision-making at all?
Yeah, so thank you for that question. And obviously, this is not a question appropriate just for thyroid cancer, but it's something that I think scientists and clinicians in the arena of prostate cancer, breast cancer, are all trying to understand. And I would say, taking sort of your last question first, where does the patient fall in this? So there is a science of patient preference, which is called discrete choice experiments, where we are looking at how patients weigh risk and benefits based on their life experience, their unique truth, their values, and their attitudes. And those data are just starting to emerge now. They're actually more robust for the decision of lobe versus total, but they're certainly not yet robust for the question of active surveillance versus surgery. So this is a question we're struggling with right now, writing the guidelines, and what should the role of active surveillance be? And your question is really good, because it's like, if you're going to do it, how long are you going to do it? And you can see in Japan, they were doing it for potentially decades. And when you follow someone for decades, you assemble cost, which I showed you before. And I would say we don't have good answers. I'll give you a sneak peek. We just completed a systematic review and meta-analysis looking at all the data in the literature around this topic to see whether ultrasound and/or ultrasound and thyroglobulin levels are appropriate. And I think our conclusion is that thyroglobulin is not, repeat, not a useful metric, and largely this will come down to ultrasound. My big problem with this, and I became aware of it in North Carolina, Dr. Schulich, was there are a lot of impoverished, indigent, rural, poor patients in North Carolina. And we simply could not do active surveillance there because of their inability to comply with the recommendation of returning again and again and again. So first of all, I don't think it's practical in some populations. And I think your question about patient preference and cost is outstanding.
Great, thank you so much. So Dr. Haugen is chiming in. And first, there was a comment and then a question. So his comment was, fabulous presentation, Dr. Sosa. And then the questions. I have many questions, but we'll start with one. How do you biologically explain the 6 lymph node threshold for survival in young people? Are lymph nodes associated with some other risk factor?
Yeah, so thank you for that. And, so great question. Don't have a good explanation. What I will say, and I'd be interested, Dr. Schulich, in what your thoughts are, but I will say that I think the AJCC, UICC staging system, like many other thyroid cancer staging system, AGES, MACES, are antiquated and arcane. And I think increasingly all of us have pivoted to better understanding of the molecular profile of tumors. And ultimately, the way we need to think about patients is not just the size of their tumors, whether they have lymph nodes or distant metastases, but integrate into that the molecular profile such that we can not only stratify based on 3 criteria, but truly personalize treatment by a more exquisitely sensitive and specific system. So what are we catching with the data I showed? I don't know. I think it's a pretty crude sword. We were unable to adjust for extranodal extension, size of lymph nodes, and almost certainly they are part of the explanation. But ultimately, the question I would ask is, what were the molecular profiles of those tumors?
And then, of course, Dr. Haugen follows that up with how do you think we can use molecular prognostics in active surveillance for PTC up to 1.5 or even 2 centimeters? And I think you were getting at that, but do you have any previews for us? I'm sure you do.
Well, yeah, I don't know what I'm at liberty to say, but yeah, we would, I think if we understood the molecular profiles of these tumors, we would have a much better sense of who can be surveilled, and just as importantly, how much surgery to do. Lobectomy, total thyroidectomy, prophylactic central lymph node dissection, you know, utilization of radioactive iodine, clearly falling out of favor overall, but how to triage patients, I think, would be much better. Now, the papillary thyroid microcarcinomas are a different problem, see, because now we are recommending that we not even biopsy these tiny tumors less than 1 centimeter. So Dr. Ringo brought up the other day, well, what if you have, you know, a TERT positive, you know, papillary thyroid carcinoma that is 9 millimeters in size? Would you actively surveil that tumor? Well, you would only know if you biopsied it. So we're sort of chasing our tail. And I think these are evolving issues. I think we're going to be arguing about them for the rest of 2021, probably into early 22. So I'd be looking in 2022 for the next iteration.
Dr. Sosa, you're not my only colleague who likes to stir up controversy. So Dr. McIntyre just put something on the chat. Why should we be training endocrine surgeons when colon, prostate, breast, and lung cancer is what leads to mortality?
Well, you know, the data I was showing, it was intended to say that I don't think mortality is always the best metric, meaning morbidity, financial toxicity. These are very, very important outcomes. And this is a cancer that impacts young people. And so I would argue the greatest impact is the impact you have on a young person who then has exposure for the rest of their lives if a complication occurs. And even if they survive, the costs, the anxiety associated with surgery, remedial radioactive iodine treatment, and the like. The question, though, you raise about training thyroid surgeons is an excellent one. And I'm very conflicted about this. And I actually think I'm part of the problem in that at UCSF, like for Dr. Davis, we train excellent endocrine surgeons and then we keep them at San Francisco. And it's like, how many endocrine surgeons can live in the city of San Francisco? Well, right now the answer is like 7. And instead we should be thinking, how do we disseminate endocrine surgeons to increase their surface area with patients? There are whole parts of the Western United States and the Southeastern United States where there is an extraordinary paucity of experienced endocrine surgeons. And that's where the low volume surgeons are operating on patients. And the data I showed you are being experienced. So I think we need to think differently about how to train and then how to incentivize surgeons to go to different areas of the country where there are.
So I see a little of John Cameron has rubbed off on you and me with that concept of disseminating surgeons, right? So
the diaspora.
Right. And then Chris Rayburn commented, fantastic talk. How do you convince your patients and endocrinologists to continue surveillance? And I know you touched on it with your talk, but you know it's the right thing to do. The data state that it's the right thing to do, but how do you actually put that into practice when a patient knows they have cancer and a primary care doctor or an endocrinologist knows that there's a cancer sitting there?
Yeah, I'll be honest with you, and maybe it's from being chair. I've stopped trying to convince anybody of anything.
This cold air is coming out.
Yeah, I don't try to convince patients, and I try to be impartial. I try to provide the options in a balanced, evidence-based way, and then I allow the patient to make the decision, and I respect that opinion. I sadly don't think I'm efficient in how I do that, and what I would argue all of us should be doing is working in the space around discrete choice and patient preferences, because if there was a way to better understand patients upfront and what their values and attitudes are, we'd be able to cut to a chase and present them with the data most salient to them to allow them to make a faster, more robust decision. But yeah, I don't convince anyone of anything, actually.
Well, Dr. Sosa, Julianne, thank you so much. That was a wonderful talk and a great question and answer. And the University of Colorado team has a goodie bag headed your way. And I hope you enjoy the items in it. And again, thank you so much for spending time with us. And I really look forward to when we can meet again at a meeting. So hopefully not too far distant in the future.
Thank you so much. It's been a privilege. Stephanie, we'll see you soon.
All right. Take care. Everyone have a great day. Thank you.
All right, ciao. Thanks so much, y'all.